today we're really lucky that Erin McCabe, nurse with the Regional Palliative Consultation Team, has taken time out of her busy day to join us to chat about GI symptoms in palliative care. So I just want to remind folks, you can unmute. This isn't a kind of webinar where you can only put things in the chat. You can put up your hand, you can ask questions, and you can also put things in the chat. But if you want to share your screen, if you want to unmute and speak up, we welcome that interaction. Because we are recording, though, we just ask that you not share any sort of confidential information that could identify a patient or a family. So without further ado, I'll turn things over to Erin.
Thanks, Val. And thanks for having me here today. I kind of wanted to start out by saying that this topic is I'm very interested in. A lot of my time is taken up with GI symptoms because it's so vast in palliative care. So it's kind of a fun one, but it's big. So we'll do what we can today. The other piece is that I've worked with RPCT for many, many years. I'm very passionate about palliative care, but I'm almost more specifically passionate about nursing in palliative care and the role of the nurse, and empowering nurses to be confident in palliative care and just do really great palliative care. So I do hope that we can have some discussion through this today and jump in. I like to hear some of the barriers that you have and try to work on those things and get your perspective. So hopefully we can be a little bit interactive that way because it's for you today. So with that, I think we'll go ahead. We have an hour, so I'm hoping we can look at these sort of main topics in GI for palliative care and maybe hit on a bit of a specific case. So what we'll look at today are sort of oral complications. This is very common to have many issues orally in palliative care. We'll look at nausea and vomiting, a little bit about bowel obstruction, and of course, constipation. Now, I'm sure working in retirement homes, constipation is a hot topic. Gets a little more specific and focused in palliative care than sort of the general population. So we'll review that today. So the oral complications that kind of come up in palliative care, there's many, including, of course, with treatments and chemotherapies, you might have some pretty common issues like taste alterations, some dry mouth or xerostomia as it's called, inflammation in the mouth related to the treatments. Sorry, my slides are going ahead without me asking them to. It must be switched on that they're doing that. I don't know if I can quickly stop that. I'll just escape from that. What do I need to click here, Carl? Do you see what I need to click to?
So it's just going
automatic.
Oh.
Nope, that's for the monitors. Sorry. We deal with this now.
Timings there. Maybe if you unclick use timings.
We'll try that.
Do you know, Val?
We'll give it a whirl.
Yeah, maybe that'll help. I haven't had that happen before.
Yeah.
It's okay. Yeah.
There we go. We'll see what happens. I'll move this. Yeah. Very common also are fungal infections, and we'll look at that a little bit closer today. Okay, now it's not letting me. Yeah, okay. So everything, at the basics with issues in palliative care, any sort of mouth issues, we're going to need good basic mouth care. But as I was working on this presentation, I was thinking that there's going to be different levels of this required for you. Like a lot of patient or residents in the retirement homes would be still doing their own mouth care even when they're receiving palliative care. So your role might be more about encouraging and checking on that, and if their oral care changes have or if their oral care needs have changed. For example, they're doing their own oral care and they usually used a toothbrush, but now they've had some treatments for their cancer and their mouth is more sensitive. Do we need to look at what they're using, products, softer toothbrushes, that type of thing? But to just encourage them to do it on their own. They might be that independent. Or you might be caring for somebody where the mouth care needs to be done by your team. And so you might be looking at doing that yourself, possibly delegating that with the support worker staff that you have, but having a care plan that includes at least twice a day cleaning of the mouth in some sense, whether it's full teeth brushing or it's cleaning with a gentle swab to get that buildup out of the mouth. That's often more closer to end of life when a person might need that care from you or from your team. But I'm thinking often that they need to be reminded to do their own good mouth care when they're in those treatments and still receiving palliative care early on. This could be a time too with mouth care as they're getting closer to end of life that we could be encouraging families to get involved. Sometimes we have to invite them to do that. I've certainly had families that have balked at that and really don't want anything to do with providing mouth care, and that's okay too, but checking with what level they're comfortable at and showing them and demonstrating how they can do mouth care. When someone's closer to end of life, really there's no maximum amount of mouth care that can be done if the person's tolerating it. It's nice to frequently, every couple hours, every hour, if they're tolerating, to have that mouth sort of cleaned up and moistened with a swab. But again, we need to check on the comfort level, and if it's not there, what can the team provide for them? Or maybe there's no family there and the team's providing everything. Again, products come into play and availability too. So I just encourage you to reflect on what you have available in your setting with respect to those, like the picture of the little swabs there, or maybe it's a soft toothbrush that's used. We always encourage families to be careful with the swabs, to not leave them in the glass of water beside the bed, because they can loosen the glue on them and then the sponge might come loose, but rather they're a one-time use swab that we throw out in the garbage after. And we do try to reiterate that frequently with the teams and with the families as well. So I was kind of wondering if this might be somewhere where anyone could jump in to consider how to get a good oral care plan going in your workplace, and who might carry out those tasks in your specific workplace, or if you've ever had an issue with that, or could speak to a time where they've had to provide oral care and it's gone well, perhaps. I'm thinking closer to end of life.
So if folks want to unmute, turn on your videos, you're welcome to, or you can put stuff in the chat related to Erin's question.
Or are nurses delegating this role to the PSWs or UCPs in your workplace? Is that what usually is happening, or? Okay.
Not seeing anything coming up yet.
Okay. Okay. Let's
a comment from I'm assuming a care coordinator. I usually send a delegated task to the service provider organization to do mouth care.
Hmm.
And then Shannon said most of the time we have personal support workers assisting with oral care. So a good point about delegation and making sure it gets followed up on, right?
Yeah, and that's sort of the key here is that, who's going to do that? Who's going to delegate it and follow up on? It really requires a team approach, as mostly everything does in palliative care. Okay. So another big issue to watch out for in palliative care would be thrush. Oral thrush can happen commonly because the risk factors for oral thrush are great in patients with advanced cancers or just advanced illnesses. Being immunocompromised would be a big risk factor for oral thrush, as well as certain common medications we use in palliative care. So that we need to be really on the lookout for this. I like this because it's quick. You can take a quick look in someone's mouth. Maybe you're, assessing them, listening to their lungs or something else. You can always remember when you're up close to them to tag it on to take a good look in their mouth quickly while you're there, daily if you can, just to see what's happening in there. And what you might find is that they might have these white oral sort of plaques, a little bit kind of chunky, a little bit kind of gummy, not pleasant to describe, that can be on the tongue, but also on the inner cheeks. I find them a lot at the back of the inner cheeks and can be on the roof of the mouth as well. And this is a fungal infection that's occurring in the mouth that can have a lot of negative effects that we really need to treat for that patient's comfort. It's kind of, when we do find it, I'm almost kind of happy sometimes because it can explain some of the symptoms the person's been experiencing, and it's because it's treatable, we can get rid of it and usually make them really comfortable. So for example, this can be causing some burning sensation in the mouth, some difficulty swallowing, which we'll often see, as well as some nausea. So if you're assessing for nausea, you're going to want to assess make sure you're checking that oral cavity and looking for that possible oral thrush that could be in there. So if we do decide, or if we do see this and we report this and have a treatment plan in place, it's often nystatin suspension, which is a liquid. It's a little bit of a yellow liquid that they need to use several times a day, up to 4 times a day, to rinse in their mouth. So it's heavy in a nursing responsibility that they take this medication properly, because they need to swish it around and swallow this medication to coat the esophagus. Because it can be all down within the esophagus, and to not eat or drink afterwards for that. And while we're treating this, we need that good oral care again. It all comes back to that. This slide is not on here to go over it all, but rather just to note that there's a lot you can be checking for and documenting with a mouth assessment. That you can see quite quickly with a good peek in the mouth with some light, and that we should be tracking that and whether it was done or not, so that we don't, or so that we can assure that someone has been looking in the mouth for patients that are receiving palliative care, because it's so common that there's issues. So nausea and vomiting is very prominent symptom. If you've had somebody with some severe nausea while you're treating them for palliative care, you might have noticed that can be quite debilitating for patients, and should be treated as quickly as possible because it has a huge impact on their quality of life. Just with how sick and horrible they're feeling with this nausea. So I like to think of it as a bit of an urgent symptom, although sometimes we can't fix it that quickly, but we need to really, if it's there, we need to, assess for that, and we need to address it as quickly as possible with a primary care provider or whatever treatment team that it is. One of the other key things with nausea and vomiting would be that there's many reversible causes. And so we need to be a bit of a detective with these and try to do a really thorough assessment and present that to the team so that we can try to figure out what is the problem, or multiple problems sometimes, or multiple causes, and treat the right one. And if it's reversible, try to really get at that. And along the same lines as that is the really good around the clock treatment for nausea if it is persistent. Remembering that if they're vomiting, the oral route's probably not good. This might be a time we have to get into some subcut medications. And the follow-up for nausea and vomiting is really important. We need to find out, is the medication working? Because there's so many to choose from. That we need to really do the reporting back to the team if it's working or not, so that we might try something else or add something else. Some of the causes of nausea and vomiting that you might see with respect to palliative care, again, could be the thrush. It could be related to another symptom such as pain. With severe pain, you might start experiencing some nausea. So that we need to look at the whole picture of all of the symptoms, because it wouldn't be appropriate to treat nausea that's related to pain with an antiemetic, but rather with pain medicine. So that's where we need to be really clear in our assessments. There's many drugs that can cause nausea as well. So we might want to see what they're taking, or if they started something new, and really sort of feel that out. This slide, again, is not to learn all of the pathways related to nausea, but rather that to show that there are many receptors in the body that lead to the vomiting center in the brain. And that's, again, where our really solid assessment's going to come in, so that we can use that information to determine what might be the cause, and then to choose the medication that might hit on the right receptors for that type of nausea and vomiting. There's a list there at the bottom of the different antiemetic medications that we commonly use. Some of them are oral, some of them are oral or subcutaneous, and the receptors that they hit. And there's a lot of overlap within them as well. That we need to consider if we're stacking some of these medications, because they might have too many side effects when used together. We highlight here that methotrimeprazine, or also known as Nozanan, you might have used. It hits a lot of the receptors, and sometimes you'll see that used in palliative care for nausea and vomiting when we're trying to get broad receptor coverage. For the most part, you're going to see a lot of metoclopramide. Also, you might hear called Metonia used in palliative care. It's a pro-motility agent or pro-kinetic agent, so it keeps that GI tract moving, specifically the upper GI tract, to keep that flow that's often slowed down with opioids that we're using, morphine and hydromorphone, often for pain management. And so we might get some nausea related to that, and the metoclopramide can help keep that moving of the GI tract. You might see that with the Metonia, you'll see some cautions in palliative care, because if we're worried about a bowel obstruction, it could cause pain when we give metoclopramide, because the motility effect might push against the bowel obstruction. We'll touch on that a little bit in that section, but for the most part, you'll often see metoclopramide used. You'll see that in palliative care, we don't usually love Gravol, although often it is a go-to medication because it's so readily available over the counter. And in the general population, we might use that. But if we go back to the receptors that it hits on, the type of medication it is, it's works with the histamine system, and that's not often an issue in palliative care. We're seeing Gravol used for motion sickness and things like that, and that's not usually what the cause is. So you might see that some of your residents are purchasing this medication, but it's usually not going to be helpful and has a side effect profile that can be concerning in the frail population as well. So we'll want to look at getting something prescribed more appropriately for them. Won't go too much into the other ones, because I kind of want to focus here on the sort of assessment that will contribute to the choosing of the medication. Oh, sorry, just gonna get to that. Sorry, just trying to get to the right one. Oh, no, I took that point out. But I did want to ask, or if anyone could add in the chat even, or just shout out some things that you might want to include in an assessment when there's nausea and vomiting to present to your team, so we might be able to choose the right antiemetic. Or maybe more specifically in the physical assessments, what you might want to include.
What about PO intake and then ins and outs, like how much they're taking in and how much is coming out?
Yeah, certainly PO intake. Like, is it affecting their appetite? Likely, right? Nausea does.
Yeah.
So that's really important for sure. You'll want to report that. What physical assessment might you want to do and then report?
Well, I'll answer that one. I'll say like auscultation of bowel sounds,
Yeah.
looking at hydration. Janice has mentioned in the chat, it's not so much physical assessment, but reviewing medications, looking at the last bowel movement.
There you go, the bowel movement for sure, right? And that abdominal assessment's pretty important. Listening to the bowel sounds and doing some palpation. Is it a tender abdomen? Is it a soft abdomen? Just do that full abdominal assessment and get that report included, because again, it's going to help to make an informed decision about what medication to use. You're going to want to look in the mouth, like we say, because it could be back to a mouth issue, an oral issue like a thrush that's causing that. It's a real detective work with the with nausea and vomiting to really try to sort that out. Okay. You might see, I'll just mention briefly, you might see steroids even used for nausea and vomiting. We could, people might take some sort of cannabis on their own even for that. They might want to trial that. There's some evidence for nausea and vomiting and appetite in that world. It's not first line for us, but I think we're seeing more and more that some people will choose to do that on their own and trial that. So we should be aware of that and document that so the team knows what they've been using. So then, of course, we always have our non-pharmaceutical options and strategies for nausea and vomiting. And this can be challenging in a retirement home versus in someone's own home, and where they can control things a little bit better. But we can try to do the best that we can. If they're triggered by sights and smells of food, that might be a little bit tricky in a building. But something that might we might be able to do is often with nausea and vomiting and appetite issues, plates of food are too large, and that can trigger the feeling of not wanting to eat, or even nausea, that they should be offered a smaller meal. And I've seen that happen so much that I just kind of wanted to highlight it and just have you think about your setting and what it would mean to get a different a plate sent up, or if they're in the dining room, what that would mean. Can you collaborate with the team? How does that get done? And just kind of reflect on that, because it can be often missed, but it can make quite a difference just to have a smaller meal offered and not feel so overwhelming. Okay. Let's check the time here. Okay. So for bowel obstructions, we'll touch on that today. And if there's anything maybe that you wanted to know about it specifically, you can throw it in the chat, and then Val can let me know. But it's a pretty broad topic. So I just kind of wanted to overview it and talk a little bit about your role in that. Usually when bowel obstruction is involved, there should be quite a team involved, because there's so many aspects to it, and it can be complicated to manage out of the hospital, but it certainly can be done. But sometimes it seems a bit intimidating and scary. So it's good to have a solid team there to support you with that. So bowel obstructions occur often because there can be many reasons for them. It could be related to a tumor or constipation. It could be an issue with the bowel twisting or some adhesions. There could be a large amount of ascites that's pushing on the bowel and causing compression there. So many causes of it. And types of bowel obstructions as well, full bowel obstruction or partial, and where is it in the bowel, and all of that comes into play to the symptoms that might occur and that you might see. So something that really stands out in my mind, if you had a resident or a person that you might suspect has a bowel obstruction, would be their goals of care. So for somebody who might be early on in their illness trajectory, they might want full investigation and maybe even surgical management of a bowel obstruction, which of course would require them going to the hospital and having them managed there. But somebody else might not want to go to the hospital and might want a medical management of a bowel obstruction, which is more likely what you would see, or you would be getting somebody back from the hospital who went in to have it managed. And maybe it couldn't be reversed, and now they have this obstruction and they're coming back to their home, possibly for end of life, or possibly the obstruction has reversed somewhat and they're going to do well for some time, but be at risk for further obstructions. So when you have somebody with this, it will be more of a medical management situation, which means that we're going to try to manage the bowel obstruction in a couple of ways. One might be we can try to reverse it with medications, or we might just be trying to work on comfort. So if you have someone with a bowel obstruction, or you're suspecting that they have a bowel obstruction, what might you want to include in your assessment? And again, that would be a good GI assessment, which might include, like we said previously, their intakes, definitely their output. Are they producing stool? What is that stool like? How frequent is it? A really solid abdominal assessment as well, and looking at other related symptoms. So you might expect with bowel obstruction that a person could have pain, quite severe pain, quite possibly a quite sudden onset of pain as well. They may or may not have nausea and or vomiting, but tracking those symptoms. I would also be wanting to consider anxiety. A bowel obstruction can be very scary. The meaning of a bowel obstruction could indicate that their disease is now worse. It could indicate that they're getting closer to end of life, and that could be quite anxiety provoking. So again, with a bowel obstruction, we'll need that full sort of wholesome assessment using, if you're using in your setting the ESAS or the Edmonton Symptom Assessment Scale, be a good time to use that to look at those common symptoms and get them rated to see how this is all coming together with this bowel obstruction and how it's really impacting the whole patient. So when there is a bowel obstruction, it could be, like I say, it could be managed different ways. So if they're looking for some decompression with a nasogastric tube, again, they're going to likely be going to the hospital for that. I don't think we're doing those in the retirement homes. They could possibly come home with one, but likely not be initiated. But if they are staying in place, they might just be NPO for some time to give the bowel a time to rest, to see if that obstruction might open up. Depending on the cause, there's a chance we can get it opened up and get that bowel functioning again. They might need some electrolyte correction with fluids or other treatments, but again, they might not be getting blood work depending on their goals of care. I'm not 100% sure on the discussion about all of this in your setting. It's something you might want to reflect on, is who will be talking about to the patient about these options in your setting. Was it going to be the doctor, nurse practitioner, you, or more of a team approach? I'm not sure, but you might want to reflect on that. While we're trying to figure out what we're going to do and how it will be managed, because often these symptoms are very present of pain and nausea and vomiting, as we might want to start getting that under control. So something you could do right away is give someone their pain medication if that's occurring, and try to get them settled that way, as well as any medication for nausea and vomiting, which will likely need to be an injection at this time. Okay. The other medications that we'll often use in bowel obstruction would be medications that reduce the flow of fluids into the gut. You might have heard of octreotide, or actually likely maybe not have heard of it because we don't use it too often. But in bowel obstruction, it can be a very helpful medication to reduce both pain and nausea and vomiting by reducing the flow fluids being reabsorbed back into the gut and building on top of that obstruction. These fluids are sort of building on top of it, which can cause more pain and vomiting. And the octreotide will slow down those fluids coming in so that we're not getting that pressure on top of the obstruction. That would be a medication that you might possibly be administering in this situation. So again, there's a lot to track when you're managing a bowel obstruction, you know, because it can have so many symptoms associated with it and so many injectable medications associated with it. And I don't think today we can get bogged down in how to use all of those medications, but rather I'd like you to think about today about any concerns or times when you've had to do this, and maybe what worked or didn't, or what you might be thinking about to manage a bowel obstruction in your setting. I think in retirement homes, it's often collaboratively with the staff at the retirement home with the service provider nursing, coming together and working together. I've seen it most successfully managed in a retirement home when the service provider nursings are really working closely with the nurses in the retirement home and having that communication and breaking down any barriers to that communication. Is there any experiences around this or concerns or?
I was just wondering, Erin, like, does it make sense, you know, if you have somebody with a disease process where this is a likely side effect, likely to happen down the line, you know, when you were talking about the goals of care conversations, like, I think it would be really important to say to somebody, like, this might be something that comes up down the line. What would you want? Like, do you want us to just try to manage and keep you comfortable at home, or do you want to have more interventions? Like, how does that usually play out to try to avoid like transfers to emerge and those kinds of things?
Yeah, I think that's probably one of the key points is to have that discussion. And I would say that if you didn't feel comfortable with that discussion yourself, because maybe you haven't done it, or you just feel like maybe you need more knowledge about it, that you could advocate for that discussion to happen with the team, maybe to the primary care provider, the doctor or nurse practitioner, to say they've had bowel obstructions or they're at risk for them, because they have a lot of disease in their abdomen with cancers like ovarian cancer, colon cancer. They could be at risk. Can we have a talk about this, and advocate that that's talked about? If it's not your role to do that, because I know nurses have different roles in different retirement homes. So maybe reflecting on, is that in your role, or is that more of a team role? And think about when those discussions might happen. It's a really good starting point, I think, for the whole topic of bowel obstruction, is to have that.
Nothing else has come up in the chat while we've been chatting.
Okay. Okay. I did want to mention here, actually, with the symptoms that occur, and the initial sort of rest of the bowel that occurs with the bowel obstruction. If we give the bowel a rest and try to treat it medically, by trying to open up a possible obstruction, sometimes we'll use dexamethasone to bring down inflammation in the bowel, which might open it up for some time to allow flow through the bowel. Some of the questions that come up around that is, can the person eat again? What can they do for intake? And oftentimes with these partial obstructions, and when they open up, they can get back to gently taking in a diet, slowly at first, of liquids and maybe some softer foods. And sometimes they return to a full diet, and they go along quite well for some time before they might obstruct again. So I just encourage you to think about that they don't have to stop eating. They may not have to stop eating when that opens up, like for the rest of their life. Like, they may get back on to eating again. And if you're not sure if they should be eating, to reach out to the team to find out for the patient, because often they can return to that and kind of keep cycling with these bowel obstructions, until it might be a full obstruction that's not reversible, which at that time, they will be transitioning to end of life. Kind of did the assessment at the beginning of this. Sorry, I think I'm missing one slide here. Okay. Sorry, I'm just missing a heading here of constipation. It threw me off. We'll talk a little bit about constipation. And please jump in, if there's any questions about it, or add it to the chat. I don't want it to be a bit redundant, but we'll go over it a little bit here. So, of course, we want our, good history of regular bowel movements when we're looking at our assessment. What medications are they using, and abdominal and a rectal exam is often forgotten, but we can find that there can be a lot of stool in the rectum that needs to be disimpacted. Often that part is missed. If we need to go further with the hospital, we might need x-rays and such to find out what's going on. But what I really wanted to say here on the assessment piece that I see in retirement homes is, again, often people are living somewhat independently, and so you don't really know what's going on with them, because I don't think you're tracking everybody's bowel movements. But certainly when they're at that risk for constipation, or have a history of constipation, or perhaps are started on opioids, which we know are very constipating, then we might want to be getting them on to some sort of regular assessments to track their bowel movements, or encourage perhaps the person to track them if they can still do that, depending again where they are in their illness trajectory. When they're more end of life, this all might seem more obvious because you'll be more involved. But I find when they're a little bit earlier on and the nursing team's a bit less involved, then sometimes then this is missed if the person's not reporting it to you, because we're not tracking it as much. So I'd encourage you, if you think they might be at risk for constipation, to get involved in some sort of tracking with them as to how their bowel movements are going. And to remind the patient that, constipation is more than just going days without passing stool, but if they're straining, if their stools are dry or hard, that's also constipation. So I tell people that all the time, because I don't think that the patients realize that, and that if they're having to strain, or they can lead to more problems, pain, and more issues. So we want to have good, easy to pass bowel movements. So with with opioids, we've got to do something. We've got to intervene, and we've got to start tracking. Most commonly, you'll see with them that you'll have Senokot available or added as a regular medication once we determine their needs. Or more and more, we're seeing Restorelax. But Senokot can work really quite well as an oral tablet at night when someone's taking an opioid to keep good bowel movements, because we know the bowel is going to be slowed down with the opioid. So what I find tricky is that Senokot could be sort of ordered blanketly as 1 to 2 times at HS, but people could certainly take much more Senokot than that. And I think it's part of a nursing role to sort of to follow up and say, is the 1 to 2 tabs a night working? Or do we need to increase that or add something to that? So again, it's that good assessment and sort of that follow-up afterwards if they're constipated or taking opioids on what's working. The Senokot works by increasing that good peristalsis movement to keep the bowel moving. Whereas the Restorelax or lactulose are osmotic laxatives that are causing more water retention in the colon. So they're working differently, which is why you'll often see a combination of Senokot and Restorelax, which is labeled here as polyethylene glycol, because they're working differently on the bowel. So when the constipation is getting a little bit tricky to manage, we might have both going on. Bisacodyl that you see there is like your Colace, which in palliative care we know isn't as effective, so we often don't use that. But I do meet a lot of people who don't want their Colace taken away. So if they love it and then they swear by it, we'll let them keep it. But I don't usually start them on that. Lactulose works really well too, and it's covered So we need, I know everyone's going to more of the Restore-Lax, laxative products, but we have to look at the cost of medications for our patients and our residents. And the lactulose can be covered for them. And the Restore-Lax is quite costly. But again, the toleration to lactulose can be less because it's kind of gross. Some people don't mind it. So if there's Senecot in your Restore-Lax and that it's not working, we might have to do some rectal stimulation in the form of a suppository or a fleet enema, possibly, when the constipation is not clearing. I'm thinking long-term care. There's a lot of bowel protocols in retirement homes. Do you have the protocols that you're following if there's an issue? Anyone? Maybe some do, some don't.
It's not really a standard thing. It's more so in
No.
hospitals and in long-term care.
Yeah.
I've seen a lot of retirement homes where they will add like PRN medications, like, if no bowel movement after 3 days, give this or whatever, but it's not a standard thing.
Yeah. Yeah. Which can make it a little more tricky. And again, it's that blend of people being quite independent or families helping versus that sort of full nursing where they're managing everything. So I think it's recognizing when there is an issue to get in there and get onto the care plan, what the next steps are going to be, or to tracking what's effective and what's not, and then reaching out to the team to see what the next steps are going to be. Okay. And that's what we were saying. So if you're working with a patient receiving palliative care and they're started on opioids, I would just always have a little flag in my mind to see if they have available or are taking usually a Senecot to start with, just to kind of always remember that and always check on that, because likely they will get constipated, most likely. And then to follow up if that's effective. Because for some people, one Senecot at night can clear them out completely. And then for other people, they're just needing multiple modalities. Everyone is so different. So that's where it always needs to be tracked and checked. And I put a little reflection here. So how is this tracked or documented, flagged, reminded in my workplace? Because again, every place is so different. So if you could just think for a moment on, oh yeah, how is that tracked for us? Like, how would I manage all of that and track all of that? And again, with the blend of independence versus the nursing support, it could be very tricky. It's a complicated setting that you're in. And I think the key to it is sort of a collaboration, because it is tricky too when you have the service provider nurses coming in as well, who's tracking what. So it's a time where we need to have conversations and communication so that it doesn't get missed. Okay. Anything about constipation or concerns in your setting, or something that's, you guys have a good way of working on that as a team? Okay.
Yeah, most of the participants here are my care coordinators. Unfortunately,
care
we don't see I don't see a lot of the retirement home people that we invited, unfortunately. So
I would have
yeah,
no,
that's okay.
Differently.
We have certainly extended the invitation to our directors of cares and partners in the community, but I'm noticing that they're sort of sporadic when they come and they don't come. And it's too bad, because this is a huge issue.
Okay. So, okay, I wonder now about the case study. It's more like nursing, but we'll see. We'll look at it maybe from the perspective of the care coordinator. I could have taken that approach, shoot. So I guess I just wanted to look at this in general, a little case study to see what the sort of steps might be and the responsibilities in the retirement home setting. So I was looking at an 82-year-old lady with COPD and diabetes that's receiving palliative care in her retirement home. And she lives in a private room and receives assistance with activities of daily living from the staff. So she's not fully independent. So the nurse notices that she has on her tongue, she has some white patches on her tongue, and that the mucosa is slightly reddened. And the patient or resident reports some discomfort and burning in her mouth when she's eating or drinking. Right away, the nurse is suspecting that she has an oral thrush and wants to investigate further. What could the nurse in the retirement home do as her next steps in this situation? And so we can look at some of the next steps that there might be. So I wanted to see what the nurse might do with her assessment in this situation. What might be the next steps there for to include in a physical examination, their history or symptom assessment. But I don't know if I have the right audience for that now.
You're lucky. The majority of us we're all healthcare professionals. There's quite a few RNs on the call. A couple dietitians, couple OT, a social worker or two sprinkled in.
Yeah. So, well, let's just run through it then for the sake of it. So, of course, with your assessment piece, you're going to need a good physical examination of the oral cavity, but also would likely include an abdominal assessment here, listening to bowel sounds and checking out what's going on there. There could be symptom assessment. Is there associated nausea, pain, anything else going on related to this possible thrush? We need to consider the medical history because with COPD, perhaps she's been treated with exacerbations recently with antibiotics, which puts her at risk for oral thrush. She also has diabetes, which is another risk factor for oral thrush. So she has good reason to have an oral thrush. And we need to sort of lay that all out in our assessment when we reach out to our team. So the nurse should take her assessment and contact in whichever way they might think appropriate to the team, to the physician or possibly nurse practitioner to get a confirmation of that diagnosis and a treatment plan. Likely they'll be getting a treatment with an oral, possibly nystatin, which is a liquid, like we talked about earlier, that we would need to do some teaching about because it's not just a regular old pill. There's some steps with that, which could be harder to manage for some people, swishing it around your mouth, holding it in your mouth for some time and swallowing, not eating or drinking for 20 minutes after. All those steps that need to be done 4 times a day. This is intensive and can be overwhelming for some patients. So it's going to need some support there to teach the patient or their family or caregivers or whomever it is. Again, a good oral care plan during this process will need to be put in place and quite specifically and clearly documented too what needs to be done. For example, if they have dentures, they're going to need to be cleaned and soaked in some of that nystatin product. And all of that will have to be laid out pretty clearly because there's so many people in and out. So who's doing what and when, and a good solid care plan would be important in this setting. And treating any other symptoms that there are associated. If it's nausea, we'll need to look at that. Oops. And then, of course, the monitoring and following up is going to be important of making sure that there's a plan in place to check on if there's an improvement in the visual assessment of the thrush, an improvement in the symptoms of the thrush, and reporting that out to the team, to the primary care provider. Okay. Sort of ran through that, and that brings us to the end of our time. There's a couple of minutes if there's any questions or anything or comments. It's a big topic.
I thought it was interesting that Nadia commented on that. It's National Dietitian Day. So
Oh.
great day to be talking about GI symptoms.
That's cute.
So unless anybody has any questions, don't hesitate to pop them in the chat. I suspect we'll get a bunch of thank yous, Erin, and I want to thank everybody for attending. While I know we might have a heavy home care coordinator, kind of population or group of people here today, participants. We will be posting these presentations online. So if you are working with folks in retirement homes that are struggling with a given topic, don't hesitate to steer them in the direction of our website and our YouTube channel. So again, thanks to everybody for being here, and thanks so much, Erin, for taking the time out of your busy day to do the presentation.
Thank
Thanks,
you.
Erin. Bye,
Bye
Val.
now.
Take care, everybody.